Everyone, we'd like to welcome you. My name's Paula Lomas. I'm Director of Clinical Communications at the CF Foundation, and we had to readjust our plans a little bit. Dr. Farah was unfortunately stuck in DC, was not able to get out a few days ago when we had the bad weather, so he is joining us virtually. And he will start this program. I know you're very interested to hear about lung transplant, and we are excited to hear what Dr. Farah has to share with us today. Dr. Farah, I turn it over to you.
Thank you, Paula. Well, you in the room are indeed the courageous ones to take a chance on a virtual live stream presentation, so thank you for joining us. For those who don't know me, I'm a pediatric pulmonologist by training, who recently joined the foundation and this wonderful team in August of this past year. I came from the Washington University in St. Louis, where I've been for the past 11 years, treating people with cystic fibrosis as well as lung transplant recipients for all sorts of reasons that they may develop end-stage lung disease. But for children, about half of all the kids that we see have cystic fibrosis in terms of lung transplantation. So thank you for allowing me to come in and speak to you in this fashion today. I'm really sorry that I was not able to get out of the DC area on Thursday. I do have to, a little bit of housekeeping. I need to let you know that we'll be taking questions at the end of this presentation using an easy online platform. And whether you're in Dallas or at home, sort of like I am, you can submit questions for us through your phone or laptop. You just open your browser and type in cff.cnf.io. Again, that's cff.cnf.io. Click on the name of the session, then submit your questions in real time, and we'll do our best to answer as many questions as possible at the end of the session. So thank you. Next slide, please. And next slide. Thanks. So my hope is to briefly walk you through what it's like to be on the lung transplant journey, and then also give you some insight into the initiatives that we're taking on at the CF Foundation to try and improve that journey. So the first question that anyone considering transplant, as well as the care provider taking care of someone who may be considering transplant, is being sure that transplant is the right treatment. And this really brings us to the transplant evaluation. And I know that brings about much angst and worry. No one likes to be evaluated. And so everyone gets really concerned, what if they don't like me? What if I do something wrong? No one really wants to be evaluated. And what's really important to know is that lung transplantation is a treatment like any other treatment. So one analogy would be, if you have pain because of a tension headache, an aspirin may be a very appropriate treatment for you. On the flip side though, if you're having pain because you've been stabbed and you're bleeding, aspirin would not be the first choice. So in that sense, lung transplantation is something that we have to think about in the context of whether or not it's right for a particular person. Also, within that context, we have to be very well aware that donor lungs remain a very precious resource. Approximately 16% of patients die on the wait list, and that's the lung wait list, every year. So we don't really have enough lungs to go around and just give lung transplants to everybody, no matter whether or not it's the right treatment. But going back to the process of the evaluation, it isn't a report card, and it most certainly isn't punitive. It is helpful. It allows the transplant team to discover things that may be very important to the ultimate success of the procedure later. You certainly want your transplant team to be aware of any potential pitfalls down the road and be prepared to address them, as opposed to being caught off guard and surprised during the surgery or right after the surgery in the intensive care unit. So the evaluation is really something that is helpful, and it's not a report card. What I always like to tell people when I used to see families and children with CF for their initial evaluation is that the evaluation is very much bilateral. While the transplant team is trying to decide whether or not transplantation is the correct treatment choice, as well as preparing itself for potential complications, the family and the person with CF coming for the evaluation is evaluating the transplant team and the transplant center and being certain that it's a right fit for them. Now, I'll grant you that for many patients, depending on their insurance, there may not be very many options, but for many other patients, there are many options that they can pursue. So if the transplant center does not appear to be a right fit, that person can certainly be evaluated somewhere else. Contraindications to transplant are some of the things that might be found during a transplant evaluation. Now, contraindications is another place that I know from my experience in speaking with people for the past 20 years in terms of transplantation, is something that really is evidence-based and experience-based. It isn't something that, again, that people come up with that are punitive and are meant to try and keep someone from the transplant list. They're there because we know from either the evidence or experience that certain contraindications can predict or portend a much poorer outcome. Next slide, please. So these are some potential contraindications. I'm not going to go through each of these. My point in really just showing them and mentioning them is to understand that there are a group of what are called absolute contraindications. And this for a transplant center would mean the risk associated with proceeding with the transplant in a case like this. So let's say a common potential issue in cystic fibrosis will relate to the microorganisms or the bacteria that chronically infect the airway. Burkholderia stenocypacia is one of those organisms that leads to potentially a poorer outcome, and for people who've had a transplant certainly leads to a poorer outcome. And that is why you will find that many transplant centers will not transplant someone who's chronically infected with Burkholderia stenocypacia. So what do I mean when I say that? Well, what I mean is that 1 year survival for people with CF transplanted with Burkholderia stenocypacia can be anywhere between 30 to 40%. In other words, only 30 to 40% of people who are chronically infected with stenocypacia are alive 1 year after transplant. And that is why most centers in the United States stop doing the procedure in people who are chronically infected with stenocypacia. You do find that there are some centers who continue to do so and are continuing to work to learn to improve the outcomes. And that's probably what we need to do with certain of these absolute contraindications, is support a handful of centers that take this on as sort of research initiatives. An analogy would be cancer, where you're on these study protocols and maybe developing something like that. But that's the reason that many centers will view this as an absolute contraindication. It isn't something that's just picked out of the sky, for instance. At the same time, many contraindications, as we learn more and develop newer techniques, can move from being absolute to relative or not being a contraindication at all. A relative contraindication means that we know there's an increase associated with that contraindication, but it's not so much to prevent us from proceeding with a transplant, knowing that we're dealing with that situation and we're prepared to deal with that situation, and again, underlying the importance of the transplant evaluation. Next slide, please. So you go through a transplant evaluation, and the determination is made both by the transplant center as well as the patient considering transplant that transplant is the right treatment. The next question that really comes up is, when is the right time? And in cystic fibrosis, we've actually been fortunate in that there have been lots of studies done to try and understand this, more so than in any other disease state that leads to lung transplantation. The disappointing part is that despite all the studies, we really still don't know exactly when is the right time. Karam's criteria is one of the oldest criteria that was used and adopted by the lung transplant world. Dr. Karam was at the University of Toronto at the time, and he did a study in his patients and discovered that he could predict 2-year mortality in people with cystic fibrosis based on an FEV1, so that's lung function, of less than 30% predicted, associated with changes in the oxygen level and the carbon dioxide level in the blood. Now, as I pointed out, the lung transplant world adopted this very quickly because he found that 50% of people who had achieved those criteria weren't alive in 2 years. However, the folks at Cleveland, shortly after he published that paper, came out and said, whoa, wait a minute. We did the same study in our patient group, and we found that 25% of our patients who meet that criteria are still alive 10 years after meeting that criteria. And so that led to many more models, many more studies, incorporating all sorts of different variables that we had in the registry and other variables. And at the end of the day, when they're compared to Karam's criteria, they're actually no better. So despite the fact that we know an FEV1 of less than 30% predicted really is a poor predictor for when is the right time to proceed with transplant, that sort of has been written in stone, and throughout this, the entire CF world, we sort of just focus on that FEV1 of 30% predicted. But the truth is, it has very poor sensitivity and specificity. So clinicians will often look at many other things, including increasing frequency of admissions, deteriorating functional status, need for a BiPAP or a CPAP machine, need for supplemental oxygen, lack of improvement when patients are admitted for their pulmonary exacerbations with IV antibiotics, and yet their FEV1s don't get better with those hospital admissions. And lastly, the development of high blood pressure in the lungs, which is called pulmonary hypertension. So for many clinicians, we sort of use many other variables, but the truth is we cannot predict exactly when the right time is, despite all the data. And that's one of the things that we hope to address. Next slide, please. So once you are on the list, how is position on that wait list determined? And prior to 2005, it was purely based on time spent on the list. So the person who had the longest time on the list, not necessarily the sickest, but the person with the longest time on the list, was the one who got the first crack at a donor lung. In 2005, the lung allocation score was put into place. And this was really a tour de force, using many models to try and, again, predict who would die on the wait list, but also who would benefit the most from a transplant. So the lungs were the very first organ to ever incorporate a survival benefit from transplantation into a scoring system. But still, 2/3 of the score is weighted towards transplant urgency. So in other words, that means that the score is heavily weighted to transplanting the sickest person on that list to obviously try and save that life. And the lung allocation score, again, I'm not going to go through each of these, but I'm happy to answer questions about them later. But include measures of lung function, lung capacity, functional capacity, as well as function of other organs. Next slide, please. So what does the wait list look like? So just to give you a sense of what it is the wait list consists of. And there are approximately 2,500 people a year added to the lung transplant list. Now, not 2,500 people are active, about 1,600 people are active at any given time because people are transplanted off the list, some people die on the list, and some people are taken off the list, sometimes because they're doing better. Approximately 12% of the people on the wait list have cystic fibrosis. So as you can see, we make up a small minority of the people waiting for a lung transplant in this country. In 2016, so this is sort of right hot off the presses, 2,300 lung transplants were performed, which was an increase of about 250 transplants from 2015. And the overall median months to transplant in 2015 was 3.4 months. Now, median, remember, means that 50% of the people on the list were transplanted by 3.4 months. Another 50% are still waiting. But this is more accurate than using an average because the outliers will impact an average much more than they do the median. Now, for people with CF, it is a little bit longer than for all comers to the lung transplant list. For people with CF, it is 4 months median wait time to transplant once they are listed. And waitlist mortality for people with CF is actually 21%. So it is higher for people with CF than it is for the general person waiting for a lung transplant. Next slide, please. So you're on the list, you're waiting, and you are, based on your lung allocation score, #1 on the list. Does that mean that you're going to get the next donor offer? And the answer is not really, because there are other variables that also are very, very important. So no matter what you've ever heard, size does matter. So as you can see, here is a photo of Shaq with Elijah Boykin, 2 basketball players. As you can imagine, if Elijah was a lung donor, his lungs could not go to Shaq. They would not be functional. They would be too small. And vice versa, Shaq's lungs could not go into Elijah without a lot of tailoring. Usually much more tailoring than most surgeons would be comfortable with, and would probably lead to a bad result. So size does matter, as does blood type. So if your blood type is A and you're #1 based on the lung allocation score, but the donor is a B, you can't get those lungs because that would cause immediate rejection. So the blood type has to match. And lastly, the system we presently have in the United States is a regional system. So lung donors are offered within 500-mile radii from where the donor is. So if the potential recipient is sitting in Miami and the donor is in Seattle, that even though the recipient in Miami may have the highest lung allocation score in the country, that recipient will not receive those donor lungs from Seattle. It's just too far to travel. And the ischemic time, which is the time that the donor lung is sitting out of a body, not being perfused and not being ventilated, directly correlates with something called primary graft dysfunction, which can be a very severe complication that may, in fact, lead to mortality. So for that reason, in and of itself, surgeons will try and keep the ischemic times relatively short. So region matters as well. Next slide, please. Now, this is the only curve I'm going to show you, but I felt it was very important to show you. This is a Kaplan-Meier survival curve. And what it does, it graphs survival over time. So if you look at the upper left hand, you will see 100%, and that is at time 0, which is at the time of transplant. So we have 100% of people surviving at the time of transplant. But as the time goes on and the years go on, we start seeing that people die, and you see the curve start to come down. What I want you to pay close attention to is that the purple line, the top line, represents people with cystic fibrosis. And the fact that it is on top indicates that the death rate after transplant among people with CF is slower than for any other diagnosis that leads to lung transplant. And in point of fact, even though I know in the community we often say 50% 5-year survival, that actually isn't true for people with cystic fibrosis. Now, this is data from the International Society of Heart and Lung Transplant Registry, which is really our most granular database at present. And what you can see is that people with cystic fibrosis actually live about the median, 50% survival is 8.5 years. There are clearly people who live longer than that as well. And in fact, you can see that 25% of people with CF who've had a lung transplant are alive 20 years after having received that lung transplant. So people with CF, for whatever reason, and I have my own hypotheses, but they tend to do better after lung transplant than any other group. Next slide, please. So the CF Foundation has really heard from the community how important lung transplantation is. And not only from people with CF and their families, but also even from our CF care centers that aren't transplant centers. The entire process is confusing and can be frustrating at times. So we have decided to invest and commit a lot of resources and time. In fact, we've made a $15 million investment to improve the lung transplant journey for people with cystic fibrosis. And our approach is multi-pronged and very comprehensive. One step that we're taking is establishing a collaborative network of clinical transplant centers to improve the care and long-term outcomes of people with CF undergoing transplant. And this is going to include developing guidelines specific for people with cystic fibrosis, include hopefully identifying best practices and standardizing care so that we can reduce the variability that there is amongst transplant centers. We also want to improve our understanding of the mechanisms of the biggest barrier to successful outcomes after lung transplantation, which is chronic lung allograft dysfunction. And we are funding basic science research to try and help us understand those mechanisms better. We are also empowering people with CF by providing them supporting guidance as they pursue the transplant journey by beefing up our COMPASS program, as well as right now we're in the middle of a needs assessment to better understand what resources and educational materials people with CF need as they embark on this journey. And obviously we're going to continue to advocate for people with CF amongst all of these agencies. Next slide, please. Now, this is a complicated diagram that I stole from Dr. Borowitz and then complicated it much further than she had. But this is to help you see, now I promise there's no quiz after this, this is really just to help you see how we're really taking a very comprehensive approach, and it goes beyond the science, it goes beyond the clinical care. Again, it includes advocacy, it includes providing emotional support and connection for people with CF, improving the information, improving the resources, and also we want to address the issues around access to organs. And we're doing that on multiple levels as well, including taking on conversations with UNOS to try and understand whether or not the lung allocation score accurately predicts waitlist mortality for people with CF, and if there are things we can do to improve the accuracy of the lung allocation score, which I believe will probably increase access to donor organs for people with CF. As well as partnering with Organize.org to help get the word out and make it easier for people to be organ donors. And I'm very excited about something called ex vivo lung perfusion, which is something the folks in Toronto have now been doing for several years, and it allows us to rescue marginal lung donors. So not all lungs can be used to transplant, even though a donor may have agreed to donate, because they've been damaged. EVLP allows for the opportunity to salvage lungs that have been damaged and perhaps make them transplantable. Next slide, please. So where are we now? Dr. Joe Paluski, who is an adult CF pulmonologist and transplant pulmonologist at the University of Pittsburgh, is our lead on this project, and we are very, very fortunate to have him. He brings years of experience, and he's a strong advocate for people with cystic fibrosis. In terms of that basic science research I mentioned, we received over 30 applications, and all were reviewed, and we funded the 9 best to help us better understand the mechanisms that lead to chronic lung allograft dysfunction. In terms of the clinical consortium, we received 16 applications. All were reviewed, and we feel that we have funded the 10 best, and we're very excited. In less than 2 weeks, on April 18th, we are going to have the first meeting of this group here at our national offices in Bethesda. As I mentioned, we've moved forward with the needs assessment for people with CF, and we're working with Organize, we're working with UNOS. We are also merging our CF patient registry with the UNOS registry to see what we can learn right now, immediately, to better characterize people with CF on the wait list, and again, as I mentioned, to better understand whether or not the lung allocation score is an accurate predictor for people with CF. And we are also investing in a palliative care initiative, and we have a working group that is working hard on developing CF-specific guidelines and toolkits. And I can see where these two groups, the transplant group and the palliative care group, will also work together to improve this journey for people who are faced with end-stage lung disease from cystic fibrosis. Next slide, please. And so, as I mentioned, we're meeting on April 18th. We have identified lead candidates for developing a patient registry that will be much more detailed and much more granular that we have from either UNOS or from the International Society of Heart and Lung Transplant Registry. And we're also going to establish a biorepository. So these 10 consortium sites will take extra blood, extra bronchoalveolar lavage fluid, because people who undergo lung transplant undergo a lot of procedures after the lung transplant to make sure that the lungs are healthy and functioning correctly. And any excess sample, rather than being discarded, we will be banking. So we have lead candidates for both the registry and the biorepository, where then we can access those samples in the future and for future studies, again, to better help us understand how we can improve outcomes. We're also moving forward with CF-specific referral guidelines to make it easier for CF centers to understand when might be the right time to refer a patient to a transplant center. And we're also going to develop CF-specific post-transplant guidelines, hopefully defining best practices, and then bringing in many of the continuous process improvement or quality improvement methodologies that the CF Foundation has so successfully implemented in our CF care centers. We want to do this with the transplant centers, and we're going to start with our consortium sites and hopefully address the variability in care where it matters. And by that I mean where it will lead to an improvement in outcomes. Next slide, please. So our take-home points. Lung transplantation has clearly come a long way. When people first started doing lung transplants for people with cystic fibrosis, the 1-year survival rate was 40%. And now we have 50% survival at 8.5 years. So we've clearly come a long way, but we're not satisfied with these results by any stretch of the imagination. We want to see better outcomes. We need to improve access to donor lungs, so that's not a restriction anymore. Contraindications to transplant, I want all of you to remember, are not punitive, but they do significantly lessen the chance for a good outcome after transplant. Half of those transplanted with CF are alive 8 years after transplant. Again, chronic lung allograft dysfunction is the major limiting factor to successful long-term outcomes. And we at the CF Foundation are embarking on a comprehensive approach to improve the lung transplant journey for people with CF. And I thank you for your attention, and I hope I've left plenty of time to participate and answer your questions. Thank you.
Okay, we do have some questions for you. Next slide.
Yeah, just by acknowledgements, so people can see them.
It's not going. There we go. Okay, we have some questions for you. Someone asked, a patient with bisapasia can't get a lung transplant. They just wanted to make sure they understood what you said.
So, and we have to be very, very careful about the terminology. So when we're talking about an absolute contraindication to lung transplant for most centers in the country, we're talking about Burkholderia cenocepacia, which is just one member of a complex called the Burkholderia cepacia complex. So there are many different Burkholderia species. So when we're saying Burkholderia cepacia, we have to be very careful that we really mean cenocepacia, because other Burkholderia organisms, many centers will go ahead and offer transplant, assuming everything else is okay. But for people who have Burkholderia cenocepacia, the only two centers that I'm very well aware that are presently transplanting people with Burkholderia cenocepacia are the University of Pittsburgh and the University of Toronto.
Well, thank you. Someone also wanted you to please explain how long is the ischemic time, or maybe explain what that meant.
So the ischemic time is from the time that the team that has gone out to recover the organs have taken the lungs out. That's when the clock starts ticking. And that's until those lungs are transplanted or reperfused, so that the surgeon has sewed the blood vessels and the airways to the donor, and those lungs are now getting perfusion. They're now getting a blood supply. Until that point, that is what is called the ischemic time. We typically like to see ischemic times of less than 4 hours. 4 to 6 hours are typically okay, but can lead to complications. And anything over 6 hours for an ischemic time typically means that we're going to be dealing with a complication in the intensive care unit after transplant. Now, many of them are addressable, and I've personally been involved in the care of many patients who've developed this complication from prolonged ischemic time, who have done well. But it can be a little bit of a scarier ride after transplant, leading to longer times in the intensive care unit, recovering from the lung transplant, and longer times in the hospital. But at the same time, it can be very, very serious, and it can lead to death after transplant as well. So we like to keep ischemic times ideally under 4, best under 6, and then we may be dealing with complications if the ischemic time is longer than 6.
Okay, we'd like to know, how do you repair a marginal donor lung to repair it for transplantation?
Yeah, that's great. So this circuit, basically what they do is, when they take the lungs from the donor, they put it in... It's getting ventilated, so it's hooked up to a ventilator, just like someone in an intensive care unit may be breathing with the help of a ventilator. Oh, can you hear me okay?
Yes, now we can.
Okay, so the lungs are hooked up to a mechanical ventilator, and they're also being perfused. They're not being perfused with blood, but they're being perfused with a special fluid. And this allows the team that's now taking care of the lungs to manage the lungs carefully in terms of the fluid balance, in terms of the oxygenation, and perhaps over a few hours, watch it, and it may get better to the point where it's transplantable. And as I mentioned, the folks in Toronto have published several papers on this, where they have successfully transplanted people with lungs that have been on this EVLP circuit. And they have shown that the outcomes after transplant for people transplanted with those organs compared to the usual way are just as good. So this is a very exciting potential way to increase the donor supply.
We have about 6 minutes left and many questions. So going on about Canada, somebody wanted to know, why are their survival rates better than the U.S. survival rates?
So in terms of transplant itself, because there are two issues there. One is people with CF not counting transplant, and then there's the folks after transplant. So I'm going to address the folks after transplant.
Good.
And we think part of it is because in Canada there are fewer transplant centers. So in point of fact, the experience from each transplant center is rather diverse as well as great in numbers. And we do know, there have been several studies that have shown that transplant volume is an important predictor of transplant center outcomes. So transplant centers that do more transplants tend to be better and have better outcomes. So we think that contributes. In addition, the allocation system is different in Canada, and in a sense, the organs are given to a center as opposed to a patient, and that center determines which patient within their center is best suited to receive the organ.
Someone asked, is there a different lung allocation scoring system for adults versus children?
So that is true. For the lung allocation score is for people 12 and older. For children under 12, there is a priority scoring system as opposed to the lung allocation score.
And can you describe the partnership with that CF Foundation has with Organize.org?
Yes. So we are supporting their efforts to use social media to increase the awareness and increase donor organ donation. They have managed now with 6 states, and they are continuing to try to increase this, to have those states recognize that a statement on social media, whether it's Facebook or Twitter or so on, stating that you wish to donate your organs is just as good as having it on your driver's license. So hopefully we see this spread to all 50 states.
And can you address the financial burden of transplant? Some people want to help families understand and know how best to support them.
Yes, no, it's huge. It's a huge financial burden. Oftentimes, the transplant center is not the same as your care center. You have to travel great distances to get to the transplant center. You have to have lodging there and food. So all of these are costs that are usually not taken on by insurance companies. And then there's the relocation. So once you're on a list, many transplant centers, in fact, the transplant center I worked in St. Louis, would ask people to relocate. And that could be months and months of being away from home, potentially not being able to participate in your job and working and bringing home a paycheck, while still having all these costs, not only your costs at home, but your costs where you've relocated to. Now, there are resources available. There are places such as CODA that help you raise funds to cover these costs that insurance companies do not cost. But this is a point. In fact, with our needs assessment, we have clearly heard very loudly that this is a major point of concern, and we will try and have a list and find resources for people as they undergo this journey. But it's a major concern.
We wanted to make sure that you all recognize that we do have Compass, and Compass can help those families, and we ask that you would refer them to Compass, and Compass will help them along the way. Doctor, we have about 2 minutes, or a minute and a half. Is non-tuberculosis mycobacterium an absolute contraindication?
Excellent question, and it varies from center to center. This is one where it can depend on which non-tuberculous mycobacterium. I think those centers that get concerned are concerned about Mycobacterium abscessus, but not all centers view this as a contraindication. Some view persistent positive cultures as a contraindication, some don't. Some view having negative smears, so that when they just look under the microscope, if you have a negative smear, that's okay and you can be transplanted. So it varies from transplant center to transplant center.
So our very last question is, what are the opportunities for advocates to engage about lung transplantation? Do we have something for them? Certainly in terms of healthcare
policies, letting people know in government what people with CF need, and specifically when it comes to lung transplantation and the incredible financial burden that's involved in pursuing lung transplantation. We, in terms of our own consortium and so on, we're bringing people on and we want to hear the community's voice. So certainly working with the members of our team that include Dr. Borowitz's team in community partnership. We want to hear, and in terms of looking for people who would like to serve as mentors and help guide others, we are very open to everybody's involvement.
Thank you very much. We're at the end of our session. We want to thank you, Dr. Farrow, and everybody in the audience.